Hello, everyone. Happy Monday. Michael McNutt, Director of Events and Education for WEDI. Welcome to another spotlight at part of our Road to Interoperability and Prior Authorization series, EMRs, Vendors, and Early Adopters. Please welcome Robert Tennant, WEDI's Vice President of Federal Affairs.
Thank you, Michael, and let me add my welcome. This is the fifth in our interoperability and prior auth series, and I'm very excited to hear from our experts today. So before we get started, I just want to run through a few quick overview slides, just in the off chance that this is the first of the series you're attending. As many of you know, we were formed back in 1991. By then Secretary of Health and Human Services, Dr. Lewis Sullivan. He commissioned two reports, and we produced those in 92 and 93, and those were converted into legislative language, which ultimately became a part of the Health Insurance Portability and Accountability Act. And in HIPAA, WEDI was named as an advisor to HHS. So how we do most of our work is through our work groups. And you can see here we have 18 work groups, sub-work groups, and task groups, including everything from privacy and security to prior authorization to attachments and the No Surprises Act, as well as many others. All WEDI members are encouraged to get involved. And as a reminder, if you are a member of WEDI, all employees in your organization can participate in our work groups. Next slide, please. So as I said, this is the fifth in our series. You can access the previous four on our YouTube channel, and I would encourage you to go back and review those. We do have two more coming up. We are going to focus on small providers on April 8th, and a little bit later in April, we'll focus our attention on small payers. So again, it's important for those folks to understand how this very important final rule will impact their organizations. And as always, these are free for WEDI members. And for these last two, we are opening them up free for the industry. We couldn't bring this type of series to you without the wonderful support of our sponsors, Edifex and MCG. These are both cutting-edge vendors that are offering their clients top-notch advice and products. So I would encourage you strongly to review what they have to offer. And if this final rule is one that you need to implement, you would be well served by viewing both of these organizations. We also are conducting what we're calling post-game shows, and led by our current WEDI board chair, Ed Hafner. It's an opportunity for a deep dive into some of the key issues that were raised during these sessions. And again, as part of our federal advisory role, we will be leveraging the discussions in this sub-work group to communicate concerns and issues directly to CMS. If you're interested, contact Sam at shovey@wedi.org. And as many of you know, WEDI was instrumental in assisting the industry move forward with versions 4010 and 5010, as well as the ICD-10 code set. And we plan to do something similar for this final rule. So we will be obviously providing education. We'll work to provide industry guidance. We'll be conducting surveys, in particular with this rule, because not all HIPAA covered entities are covered under this rule. We'll be seeking to identify the return on investment. And I think you'll hear a lot about that in today's session. We'll also identify best practices, issue recommendations to CMS, and we'll be using our online community forum. And we'll change slides here, and I'll tell you a little about that. we have set up an online forum that will allow you to reach out to your colleagues with questions and issues and allow for a dialogue. And if you have a question, for example, that is standard specific, whether it's HL7 or an X12 issue, we have the ability to reach out to these SDOs to get guidance there. And as well, we'll use this forum to develop communication for suggestions and recommendations directly to CMS. So let's quickly run through our agenda for today. I'm going to turn it over very soon to our wonderful speaker from CMS, Lorraine Du. Then we'll have Bob Dieterle from Enable Care Group and the Da Vinci Project to give us a technical overview of the final rule. And then I'll turn it over to David Delano, who is with the Massachusetts Health Data Consortium and also the WEDI Prior Authorization Subwork Group co-chair, to moderate what is really a blue ribbon panel of experts to talk about this rule, and most importantly, talk about their experiences, either helping or implementing. So you'll want to stick around for that. And then we're very pleased to have MCG Health give us a presentation at 3 p.m. Talking about specific solutions for some of these challenges. As always, these are interactive events. I strongly encourage you to take this unique opportunity to ask questions or raise issues through the chat. Again, we've got some of the leading industry experts on this final rule in attendance today, so take full advantage of that. And as always, slides and recordings will be emailed to you after the event, and feel free to share those with your colleagues. So with that, I am very pleased to have Lorraine Du and Shanna Hartman come back and share their expertise with our audience today. They're both with the Centers for Medicare and Medicaid Services. So with that, I will turn the floor over to Lorraine and Shanna. Thanks so much.
Great. Thanks so much for the introduction. And we are, as I said, very happy to be back with WEDI again today. Shanna and I will be talking with you again about a particular provision of the rule. And even though we talked about this maybe a week or so ago, specific to the prior authorization provisions of this rule, as we said, we have I put this disclaimer together after another presentation. We will give you policy information, and we will be specific to the policies that are in the rule, and we'll do our best to answer the questions that you may have today that come up in the chat, and Shanna will tell you how you can send other questions later on. So if you just go on to the next slide, you may have heard again, but there may be some new people today, but just to talk about something that we are very proud of. We're very happy about the reception that the final rule has received. And so just bear with us if you have already heard it, but you can never hear a good rule too many times. But the rule did come, the interoperability and prior authorization final rule did come out on January 17th of this year, and it is now in the Federal Register officially as of February 8th. And really, it is about our commitment to helping to ensure that interoperability is across not only CMS, but across the entire industry. And we are really excited to see the kind of response that we are getting to this. This rule does have both technical and operational provisions to it. And there are two sets of dates for when these provisions go into effect. The operational and process implementations go into effect generally in January 2026. Then the API provisions, which I think this group may be interested in specifically, are generally January 2027 implementation dates. But the bottom line, what we're really trying to work on is that this is streamlining the prior authorization processes and really getting a very significant burden that you all and we know has been significant across industry and that we are looking forward to seeing the impact that this will make over the next couple of years. Michael, you can go to the next slide. Again, the general provisions of this final rule are for impacted payers, for Medicare Advantage, the state Medicaid and CHIP programs and agencies, Medicaid managed care, and the qualified health plans on the federally facilitated exchanges. And the provisions, as we've talked about at the other sessions, are an enhancement to the patient access API that was part of the interoperability rule from May 2020. And then the provider access API, a new payer-to-payer API requirement, and what we'll focus on today with the prior authorization API. And then because we have this added on equation, which Shanna will talk about somewhat, in the improving prior authorization processes, but particularly focusing on what the providers also will engage in with their EHR tools. And I think we've got Hans here and a couple of other people who will really talk about the importance of that piece of this final rule. And so these are the general provisions. And then I think, Michael, I don't know if you have this slide, if you go to it. I had provided this last time, but what's important about the provisions that we added in this final rule is that because it's about prior authorization, we added to the patient access, provider access, and payer-to-payer access APIs information about prior authorization requests and decisions, so that now the patient, the provider, and the payer will all have access to this information about the prior authorization approvals, how long it's been approved for, and that will enhance the level of communication between the entire healthcare spectrum. And that was an important element that I wanted to make sure we had covered in this conversation too, is how that information will now be accessible to the patient to help with their decision-making and their conversations with their providers and with their payers, as well as make sure that that information is coming across through the entire data exchange. And that was one of the slides that I had added for our discussion last time, and wanted to make sure that this group had that information as well. And now you can go to the next slide. So here's what we consider a hallmark piece of this final rule is for the prior authorization API, that what we've done is leverage the standards and implementation guides from HL7 to ensure that the provider will be able to request of the payer, do I require an authorization for this particular service? And if so, what additional information is required for it? How do I get that information to the payer? And then what information will the payer send back to me about whether it is approved or not? So the implementations are the coverage requirements, the documentation templates and rule, and the prior authorization support. And then when Shanna speaks, she's going to talk to you about the standards that are actually required for implementing this API, and what implementation guides we are recommending as those continue to be implemented, what additional feedback can be provided back to HL7 to continue to iterate on those before we actually require those in subsequent rulemaking. And so these were this is the actual API that will be implemented in 2027. And then if you go to the next slide, in addition to the API requirement, we had also been hearing about the processes that needed to be improved. And so we added on requirements there to begin to address that, because the providers were not hearing back information timely enough to really be able to serve their clientele. So we've improved across the board, other than for the qualified health plans, which had other statutory authorities, that for expedited authorization requests within 72 hours, and for standard request for 7 days. And that really halved the process for most of the payers. And so those prior authorization decisions will be made in a much more timely way to ensure that individuals can get the care that they need. In addition, we had heard that providers couldn't make decisions on requests that were denied. And so now the payers have to provide a specific reason when they are denying a prior authorization, regardless of the way that denial is coming across. And then in order to improve the transparency of how these services are being reported, we now require that metrics be posted on a payer's website about what services are required to be prior authorized, what percentage are approved, what percentage are denied, how many are appealed after they've been denied and successfully appealed, so that there can be this broad set of information across all the payers. These requirements are implemented in 2026. This gives both payers a chance to see how am I performing and what might I want to change before the API even goes into effect. And we think this will really be helpful to not only the payers, but also providers and patients to see what the performance is like and provide some feedback as well. And I think that the next slide is going to be on our electronic prior authorization measures. And I'm going to turn the slides over now to Shanna to talk about the other half of the equation, which is from the provider perspective. Shanna?
Thank you, Lorraine. And yes, so on the provider side, for eligible clinicians participating in the merit-based incentive payment system under the Promoting Interoperability program, as well as eligible hospitals and critical access hospitals in the Medicare Promoting Interoperability program, there are now new measures titled Electronic Prior Authorization under the Health Information Exchange objective. So for these measures, an eligible clinician, eligible hospital, or critical access hospital would have to report a yes to requesting a prior authorization electronically through that prior authorization API that Lorraine was just talking about. They would have to use data from their certified electronic health record technology, or CERT, for at least one medical item or service that was ordered during that performance period. This requirement would begin with calendar year 2027 performance period or 2027 EHR reporting period for each of those programs, respectively. Next slide, please. And also, as Lorraine mentioned earlier, we did modify some standards for our APIs in this final rule. I will mostly talk about those for the prior authorization, but we did modify in this rule to clarify which standards are required for each of the APIs, which is listed in table H3 in our final rule. We also have a provision to allow the use of updated standards. So if a newer version of the standard is available, but a previous version was referenced in the rule, as long as it does not disrupt the end user's ability to access the data. And there are some other requirements that must be met in there, but we do allow the use of those updated standards. In addition, we also recommended implementation guides specific to each of the APIs, which I will mention in just a minute. Next slide, please. So this table here lists the required API interoperability standards. And as you can see, for the prior authorization API, it is required that FHIR R4 is used, the US Core Implementation Guide, as well as the HL7 Smart App Launch Framework Implementation Guide. The next slide, please. And for those recommended implementation guides for the prior authorization API, those are the Da Vinci Coverage Requirements Discovery, or CRD IG, the Da Vinci Documentation Templates and Rules, DTR IG, as well as the Da Vinci Prior Authorization Support, or PAS IG. Those three are the recommended implementation guides specific to the prior authorization API. Next slide, please. And as always, we have lots of resources on our rules and some frequently asked questions and information on how to find additional information about all of these standards and implementation guides. There are links here and also on our website. You can find a whole bunch of information and links for additional information, as well as additional technical standards and implementation support for each of those implementation guides that we either require or recommend in our final rule. And next slide. And as always, I know we'll be taking questions on this webinar, but as well, if you think of any after this, Our email address is cmsinteroperability@cms.hhs.gov, and we do check that regularly and respond to you. So if you think of any questions or need any clarification, please send us an email and we will do our best to provide that and get you the information that you need. And again, thank you for having Lorraine and I here today.
Thank you, Lorraine, and thank you, Shauna. Excellent presentation as always. And it's my pleasure to turn it over to Bob Dieterle, CEO and owner of Enable Care and Senior Advisor and Burden Reduction Lead for the HL7 Da Vinci project. Welcome, Bob.
Robert, thank you very much. I'd like to thank you and Michael both for allowing me to present and become part of this really important series that you have decided to sponsor to bring us all up to date on what's happening with the new CMS rules. Let me share my screen. There we go. Okay, so we're going to spend a few minutes talking about the technical underpinnings of these Da Vinci implementation guides that were mentioned in the prior presentation. If I can control this properly, we'll be all set. Okay, the work that we started about 5 years ago to start to address the issues related to prior authorization, we're focused on a series of goals that we wish to accomplish. One is to be able to bring patients the ability to go and get more rapid approval for the next steps of their care, in particular for those things that required prior authorization. Hopefully over time, being able to get that approval while they're still in the prior setting. So they could leave, for example, their a primary care physician's office or a specialist's office and have the next step in their care already approved and over time scheduled. We wind up living with the fact that today about 30% of all patients that do not leave a practice with the next step approved do not pursue care and wind up coming back into the emergency room of the hospital, which is obviously counterproductive both for the patient and for the cost of care. We also want to improve the ability for providers to wind up having appropriate discussions with their patients while they're in front of their patient, being able to plan together and understand the implications of the care that's being prescribed, whether that is support for in or out of network, out-of-pocket costs, et cetera. So these are things that we're trying to go in and bring to the patient-provider relationship. In addition, we're also trying to go and automate the collection of information that's necessary for a payer to approve a procedure that requires prior authorization. In other words, to collect the information automatically to show that something is medically necessary and appropriate. And then ultimately for payers to wind up reducing the overhead that it takes to go in and approve prior authorizations, avoid delays in services, which could lead to higher costs of care. Improve the relationships they have with their members and the providers, and improve documentation the first time around so that we don't have to go back repeatedly to ask for additional documentation. We have 4 different implementation guides, 3 of which have been named as recommended in the current CMS rule. The first is coverage requirements discovery. This is something that happens when an activity in the clinical workflow is creating information that may lead to a need for prior authorization, whether that is during appointment scheduling, it's during signing orders. It could be a number of other points along the workflow that we'll talk about. But what we do then is we send the information over to the responsible payer. The payer can then go and return information related to all of the services. Let's just focus on order for the moment, order sign, all the services that are being ordered, services, referrals, et cetera. And for each one of those individual items, being able to return whether it is covered or not covered, covered in network, requires prior authorization, requires specific documentation. All these things can be returned by the payer at the point when the provider is ordering those services and is most likely in front of their patient. We have the ability, and we'll talk about this in a minute, now that we have the enforcement discretion for the National Standards Group to actually turn around and shortcut the process and actually provide prior authorization right at that point. Documentation, templates, and rules, we have the ability to go and collect automatically the information from the medical record to the extent it's in the medical record, and be able to pre-populate a form, or as we talk about in fire, a questionnaire that can then be reviewed and approved by the provider, submitted to the payer. If it's an interactive conversation, which it can be using adaptive forms, then we have the ability to also return a prior authorization at that point, obviating the need for the continued steps into the prior authorization support. During prior authorization support, we have the ability to assemble the information that has been collected through documentation, templates, and rules, and the information related to the patient's services that are being ordered, send that as a bundle, either through an intermediary, if we're trying to go and convert to an X12278, or directly if we're taking advantage of either the exception that Da Vinci was granted or the new enforcement discretion that the National Standards Group has provided. So the red circle is indicating we have something new here that we didn't have at the time that we put together the original implementation guides, and that is the ability to go and communicate directly between the provider and the payer for prior authorization request and response without going through the X12278. And then finally, if additional information is being requested as part of the prior authorization process, it may turn out that the information gathered here actually raised a question. So collecting the information regarding medications, prior procedures, diagnoses, et cetera, along with information that the payer has, may indicate that there is another question that needs to be answered. And so we have the ability to go and ask that question and have it satisfied through the clinical data exchange process, gather information again automatically from the patient's record, pull specific documentation, and send it to the payer's endpoint for attachments. So coverage requirements discovery, we had an initial version that was out in STU1 that was named in the NPRM. And since then, we have done some updates, in fact, a fair number of updates to improve clarity of the guide, to describe additional places in the clinical workflow or hooks where we can go and create interactions with the payer. We remove clinical data recommendations. We define system actions that allow a lot of the interactions that are taking place during CRD to be handled automatically, such as attaching that response coming back from the payer directly to the individual service or referral, and not needing the provider to interact physically with that. And then we have the ability to respond back with particular questionnaires or questionnaire responses and the determination that we talked about. I'm not going to go through this slide. This shows the workflow. It'll be in the session today, so you'll be able to look at it. These are the hooks that we are supporting within the coverage requirements CRD implementation guide. And these are CDS hooks. So we have the ability to create a hook around appointment booking. At that point in time, and for those of you who've been on the other sessions, in particular for the provider access API, that appointment book can be used by the payer if they wish to establish a treatment relationship between one of their members and a provider that has not submitted a claim before, which would be the typical way of populating the attribution list. We can also return appropriate prior authorization information if, for example, that type of a visit or the provider with whom the visit is occurring needs prior authorization. We have the encounter start hook. This can also be used to establish a treatment relationship with a provider. Might happen when they walk into an emergency room, for example, or have an emergency visit with a particular provider. So we can do that here. We can also turn around and use that as, or a payer can, use that as the start of a session where they go out and they gather information related to that member, the plan they're on, the coverages they have, the prior authorization requirements that are required, or services that are required, and any experiential information that they may already have. They can gather that so that they don't have to worry about going out and collecting that in something like order sign, where the response time is actually quite restricted, about 5 seconds to respond back. But they have plenty of time between the time an encounter starts and an order gets signed to collect that information and make it available for the decision making that happens at order sign. We support order select, which is as optional, which is a more intensive interaction between the provider and the payer. This could provide feedback on, is that particular medication that's being ordered appropriate? That's being done. Is a particular service appropriate? So these are the kind of things that could be implemented, but we don't require it in the implementation guide. We do support it. And then finally, on order dispatch, there are situations where during the process of placing an order, all the information may not be available. We may not know, for example, the site where the service is going to be performed, or the provider that's actually going to perform the service. And so we have the ability to do the same interaction at order dispatch, the time at which the order would be dispatched to the performing provider, or when there's a revision. Documentation, templates, and rules. As we indicated, this is how we automate the collection of information. This is necessary to support medical appropriateness, medical necessity and appropriateness. We did have an STU1 that was previously published. We now have an STU, which is a significant update. It includes things like the adaptive questionnaires, the interactive collection of data between the provider and the payer. This is especially important when you're walking through a complex clinical protocol that a payer may have that could have potentially, for cardiac care, hundreds of individual nodes, but you only have to traverse 5 of them based on the answer to the prior question. So this allows us to have very focused interactions to gather the data that's necessary. We also have the ability, if we're doing an adaptive form, to respond back with the decision or prior authorization number. And a point that I need to make is if a prior authorization number is returned during CRD or DTR, it can be included in the 837. It's also important to note this is only for approvals. It is not for denials or requests for additional information. That happens through PAS. This is the journal workflow. Again, I'm not going to go through it. DTR can be launched in a number of ways. It can be launched by CRD. Basically, a questionnaire, a canonical questionnaire gets returned as part of CRD, and the CRD client can be launched by the EHR and pick up that particular canonical questionnaire or questionnaire response and go out and start the process. It can also be a delayed launch. It may turn out that based on the provider's workflow, it makes no sense to launch this a DTR at that point in time. This is something that only happens in the back office. That is supported. We have the ability to suspend the process. So maybe there are 3 or 4 questions that the provider needs to answer while they're in front of the patient, and the rest can be handled by the back office. We can do that. Or it may be that the provider doesn't want to finish the process at the time they're in front of the patient, and it can be suspended for later processing. And then there's a standalone launch. It may be that they're not using CRD for that particular point, or at that particular point in the process and the clinical workflow, but they want to go out and use DTR to collect information. And then finally, there's the interaction with PAS, asking for additional documentation using CDEX, and CDEX has the ability to also use DTR to collect information based on a questionnaire or an adaptive form. We did have an original STU1. We've done significant updates, and this is prior authorization support. We've done significant updates again for prior authorization support. We have included error handling. We have included the ability to use CDEX to request additional documentation, and ultimately the ability to have fire questionnaires used to collect additional documentation. And then we've done some updates on the inconsistency between what we had in prior authorization support and the 278 requirements. If you're going to use the 278, then we have defined a process for walking through a mapping from the fire bundle, which is created by the provider, translate that into a 278 request, send that on through to the payer, come back with a 278 response, update the fire bundle, and return it. So if you're using the 278, we have defined in the implementation guide the process for making that work, including the translation to and from the 278. If you're operating under the National Standards Group exception or enforcement discretion, or the exception that was granted to Da Vinci, then we don't use the 278. We send the fire bundle on through and we respond back to the fire bundle. So we have the ability to go and support either one of those in the current implementation guide. We've expanded the scope, as we said, to support CDEX to satisfy the request for additional documentation coming back through PAS. So this allows you to return, or allows the payer to return either specific codes that might be supported in the 278, or the LOINC code for a particular document, or a pointer to a questionnaire, any of which can be handled by CDEX to gather the information, assemble it, and return it to the submit attachment endpoint that the payer has. So we now have the ability to request additional documentation and support it. This is the overall flow from the beginning to end. It looks complex. It takes into account all of the issues related to coverage requirements discovery, documentation templates and rules, and PAS/PDEX. The arrows, or the exchanges in pink, are the ones that go from what we would traditionally consider a provider's systems, or the HIT technology they use, and a payer's systems, including those things that they may contract with third parties to support. So the pink in the middle is the base exchange. The other arrows indicate additional things that have to happen on either the provider side or the payer side to make sure the information that's necessary to support these particular transactions is available in a timely fashion and is used appropriately by the receiving party. I'm not going to go into greater detail here, but this is also available on the Confluence website as part of the work that's being done with burden reduction. So finally, benefits, interoperability, standardized transactions between all payers and all providers. So you don't have one set of requirements for this payer, a different set for that payer, a different set for a third payer, or you have different provider organizations supporting different capabilities. This is one set of specifications to be implemented by everyone. It also includes full workflow integration. So we can now go into the process that is being used by the clinician, right from the time appointments are booked till someone checks in, the ability to support order signing, the ability to go and have issues that have not been resolved up front during the order to be handled in the back office. So this integrates fully into the clinical workflow. The data being shared is largely computable. In general, the way we collect information from the patient's record is by using the 21st Century Cures Act APIs, which is part of the certification process for all EHRs or HIT. That information is, in general, structured and computable. There are some exceptions to that. We can still support the exchange of PDFs and CCDAs that have non-computable information. But in general, this is computable information. So we have common workflow expectations on both sides. We minimize the collection of documentation to only that which is necessary to support showing that a particular service or referral is medically necessary and appropriate. We don't need the entire patient's medical record or even the entire encounter. And we approach the burden on providers, patients, and payers by significantly automating the process and moving the response further up in the clinical workflow, and hopefully over time, before the patient ever leaves the care setting they're in, before they have to worry about the next step in their care. And I believe that's it. So I'm going to hand this back over to Michael.
Thank you, Bob. Excellent overview as always. We're all very excited to see how this is going to work in practice and in the real world of healthcare. So that's something that we'll hear from our panelists a little bit later on. So now I would like to turn it over to our prior authorization subwork group co-chair, David Delano from the Massachusetts Health Data Consortium, to lead our discussion with the panel. David, it's all yours.
Great. Thanks, Robert. And thanks everybody for joining today. If I could ask the panelists to please come on to video and just give a brief introduction of who you are. We could just kind of go down the list if that's okay, starting, I guess, with Lorraine, who we do know already because she just presented, and Bob, who just presented. I think we know Bob, but feel free to introduce yourself. Start with you, Lorraine. Go ahead.
Lorraine?
Lorraine again. Lorraine Du, Senior Policy Advisor with the Health Informatics and Interoperability Group under the Office of Burden Reduction and Health Informatics.
And
Thanks.
I'm Bob Dieterle. I was one of the founders of both the Da Vinci project and the Fire at Scale Task Force under ONC, and have been the lead on the burden reduction implementation guides from their inception.
Thanks, Bob. Raj, are you on?
Yeah, can you hear me?
Yeah.
David, can you hear me?
Yes, I got you, Raj. Yeah.
Raj from MCG, very excited to be part of this group. I've been working with Bob and team for many years, very actively, be part of the Da Vinci groups. And then we have implemented three times so far in various forms and shapes. Very happy to be part of WEDI and many other groups, and happy to share a lot of our insights today.
All righty. Thanks, Raj. Shanna, are you on?
Yes, hi, Shanna Hartman, CMS. I am the Technical Standards and Implementation Lead in the Health Informatics and Interoperability Group with Lorraine.
Great. And Hans, is Hans on?
Yes, I'm on. Good morning. Hans Buitendijk. I'm a Senior Director Interoperability Strategy with Oracle Health or Oracle Cerner. We're still transitioning those names. I am currently, I've been part of Da Vinci from the start as well. Currently Vice Chair of the Steering Committee. Also active in EHRA, where we have had discussions on this topic, and a couple of other places and organizations trying to advance interop.
Great. Thanks, Hans. Kirk, do we have Kirk?
Yes, good morning, everyone. Kirk Anderson. I'm the Chief Technology Officer at Cambia Health Solutions. Cambia includes the payer Regents, who has implemented these implementation guides. You'll hear more about that in a minute. And I'm also the chair of the Da Vinci project.
Great. Thanks, Kirk. Denny Brennan, I think we all know Denny, but go ahead, Denny.
Hi, I'm Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium. Dave, Janice, our team and I are diligently at work standing up a multi-payer, multi-provider, multi-standard exchange and automation service for Massachusetts. I've got to come up with an acronym for that, but I haven't figured that out yet. But I'm delighted to be here and always pleased to be a part of NEHAN's activities.
Thanks, Denny. Heidi, is Heidi on with us today?
Yeah, Hey, this is Heidi Kriz. Sorry I'm not on video. My Zoom is failing every time I try to put it on video, so I have to call back in. So hey, I'm Heidi Kriz. I am a director of medical policy and medical management at Regents, and as Kirk just presented, worked really closely with his team on the technology side to implement our prior authorization workflow. And then I lead several of our transformational efforts for Regents.
Great, thanks, Heidi. And Brian from Medifex?
Yes, hello, thanks. Brian Poteet, product manager for prior authorization here at Edifex, working on standing up all of the tooling and infrastructure tools that supports the guides and technical rundown that Bob did, among other things. So happy to be here.
Thanks, Brian. And Mike from C Omega?
Hi, I'm Mike Gould. I'm the Associate Vice President for Interoperability Strategy at Z Omega. I, like other of my peers here, have also been a founding member of the Da Vinci Project in my days with Independence Blue Cross and with the Blue Cross Blue Shield Association. So I've been very lucky to have various perspectives on implementing these burden reduction fire implementation guides for prior authorization from the perspective of a payer, as well as from the vendor perspective. So looking forward to the discussion this afternoon.
Great, thanks, Michael, and thanks everybody else for those intros. So we'll jump right in here and keep this rolling. So, as we all know, this prior authorization process has been particularly challenging. I think everybody will attest to that. We've heard from that already this morning several times. And within this rule, CMS has really laid the framework for a new approach to exchanging prior authorization data and information, as Bob just described. We're really fortunate to have this set of leaders and implementers with us today, talk about APIs and things that are actually happening in the industry in real time. So that's why we're here to discuss. So with that, we're going to start with Lorraine from CMS. We'll go right straight to the source here and pick this apart a little further. From your perspective, Lorraine, did knowing that there had been some other industry adoption of the prior authorization APIs help with the direction or influence the direction of the final rule at all?
Did knowing that help with the direction? I don't think it hurt, but I think what was more important in some ways was understanding that the issue of prior authorization was a long-standing burden, and that there had been people asking us to address this, and that we had been collaborating with HL7 in identifying what the technology was that was going to be possible to address this. And so knowing that there were innovators looking at it, and knowing that it was important to have someone in the federal government taking the lead and saying, if there are standards, if there are people that are willing to do it, was a part and parcel of that solution. But this has been a long-standing issue that we have been doing research, having listening sessions, having surveys done. So it was something that we knew we had to address. And that I'm not sure it's a chicken and egg issue so much. It's that you can't just say, thou shalt. But it was much more of a collaborative effort, knowing that there would be people who would take this on. So I think it was partly knowing that this is a longstanding burden that had to be addressed, and that the technology was definitively going to be there.
Okay, great. So just knowing that Bob was working on it wasn't enough for you guys? No.
It was a huge part of it, no question. But Kirk was there too, and other good people.
All right, fair enough. All right, so we'll shift then over to the Regents Cambia side. We're going to hear quite a bit about, I think, what's happening there because of that great example of the work that they're doing today. So Kirk, we'll go to you and just say, having already taken advantage of API technology, can you talk about your history with APIs in general and working with API and API-based exchanges, and then what other Firebase transactions you currently and or plan to support in the future? Like, do you have a roadmap for this type of work going forward?
Sure. Yeah, we've been leaning into APIs generally for a long time. I think most of us have been in the healthcare industry. But what was really exciting to us when FHIR became an open standard was that it would allow us to lean into that direction of allowing the systems that we manage inside a payer to speak more directly with provider systems. In other words, catch up to what other industries have been doing and taking advantage of the internet. When FHIR came along and gave us an opportunity to do that in a way that wouldn't be proprietary, they gave us the assurance that we could invest once and take advantage of that investment over and over, regardless of who's buying what vendors from whom. We got really excited about that, I would say about a decade ago. And so at that time, we leaned into this thing that now we know as the Da Vinci project, to really focus into the use of FHIR APIs in that payer to provider leg of the stool, both directions, because we all know there's a lot of room for improvement and modernization in that space. And so within the context of and working with provider partners here in the Pacific Northwest, we've implemented multiple Da Vinci use cases in production. So data exchange for quality measures, member attribution, and then most recently, we've been working on prior auth, which is frankly the most complicated out of all of these. But following the IGs that have come out of the Da Vinci project, working together with CMS for an exception to that 278, which now, as you heard Bob mention, isn't a complexity that we need to think about anymore with the announcement of enforcement discretion. But we put the prior auth solution in production, serving real patients, real providers, over a year ago. The results have been great. And so we're really excited now to be able to take that investment that we made in support of one provider and make that available to all of the providers that we serve here in the Pacific Northwest.
Well, we'd love to delve into further how you're going to do that, but we'll come back around to it. I'm sure that's a question on everybody's mind. So then we'll shift to your colleague Heidi for a second and just talk a little bit about that implementation of prior authorization. And maybe you could describe, Heidi, what the challenges you encountered with digitizing your medical policies, if any.
Yeah, thanks. So I would say first and foremost, before I get into that, the most important thing, honestly, at the end of the day is doing a proper PA check for the provider. So the PA check really drives the entire process for us in our workflow, so that when there is a prior authorization required based on that procedure code at line of business and the member's benefits, we drive them to the correct policy. So I wanted to call that out first and foremost. Providers cannot go in there and get an unknown response. It just doesn't really facilitate the change management that needs to happen for adoption. Our workflow is built out to drive by procedure code, as I said. So we took all of our criteria sets across different lines of business to build them out with logic. And we went through a build versus buy scenario first. We use MCG today. And so we used one of their tool sets to build out all of our policies electronically. And they all have rules logic in the background. So once we built those out, I would say, something really important is whether or not you're going to automate that approval or pen it in for a human to look at. So I have many different rules engines that fire for different types of policies and services to know when to approve something automatically without a human, or when we need to pen in for a human to look at. And I would say we don't ever deny without a human looking at it. Those go all the way up through MD review. One of the things that was really important in the rollout of the work that we did was to ensure provider adoption. So the way I kind of tackled it, as you can imagine, across all the different lines of businesses and hundreds of policies, is we really started with our highest volume policies and built those out first, because that's really at the end of the day what's going to have the biggest impact to our members and our providers as we drive automation. So I think that's a really important call out. And then I get a lot of questions, and something we actually even went through as a health plan. Is this a business initiative or is this a technology initiative? And my answer to that question is always, it is absolutely both. And I think one of the reasons that we were successful getting our work done quickly is because Kirk's team on the technology side and my team on the business side worked hand in hand all the way through from start to finish so that we truly understood the technology capabilities and they also understood the business needs and requirements. And that really at the end of the day was important. And so I would encourage all organizations doing this, you have to have both at the table equally represented. One of the other things is some of the criteria sets are difficult to build out. I think technology is getting more dynamic in supporting the policy criteria sets, but some of them can get really long and complicated, and it's hard to fit into certain rules logics that the tools offer. So I think we had to change some of our policies around. I think Medicare also was a little bit challenging because sometimes it's not a discrete. It's medically necessary when A, B, and C and D are met. There's paragraphs of information that have to be interpreted to get into some sort of a rules-based or question-based format. So that took us some time and attention. And then lastly, I'll just call out really quickly, the other challenge I've had is this is a big change for providers to move into these workflows. And their staff are often non-technical, right? Non-clinical types of people that are really trying to go through these workflows, fill out the criteria sets correctly. So there's been a lot of collaboration with our providers that are using our eAuth processes to say, hey, you should have gotten an automated approval. I have audits I do with my teams. You should have gotten approval. Like, let's make this better for everybody. What can we do to make sure that you get that approval at the end of the day? So I think plans and providers really need to come to the table and collaborate in order to create change and make this better for everybody. And there is work to do on both sides.
Great, thanks, Heidi. Wow, that's
Sorry, that was probably more than you bargained for.
No, it's fine. It's what we're here for, but it's definitely a daunting task that you've overcome. So congrats. So then, kind of tagging off of that same theme, though, then Denny, I know what we've done, but maybe you could describe to others about the prototype work that we've done at MHDC with CRD, and then also where we're going from here with particularly FHIR-based APIs and the description that we just heard from Heidi. You're on mute, Denny.
The cost of courtesy, right? I'm off mute, so you don't hear me. We did a standards-based prior authorization project. As part of a grant, we were awarded by the Massachusetts eHealth Collaborative, Mickey Tripathi's former stomping grounds, to perform a standards-based prior authorization process. And we focused on the coverage requirements discovery process, answering that, is a prior auth required or not? And we worked with Blue Cross Blue Shield of Massachusetts. We worked with Olive, I guess now part of Availity, and we worked with the New England Baptist Hospital, which is a major provider of orthopedic services in the greater Boston area. So we were looking at a situation where a very large number of services are going to require prior auth. We looked at designing a CRD process that was in conformance with the standards at that time and would still be in conformance today. And we saw the kinds of results as a result of that project that, Heidi and Kirk, Raj have seen, others have seen in implementations of ePrior auth Da Vinci style, for lack of a better term, where close to 70% of the prior authorization requests were unnecessary. And this was in orthopedics, where there's a lot of prior authorization required, but we were able to tell them in some cases, in a large proportion of the submissions, that prior auths weren't required. And then we also were able to get a direct response of a prior auth where it was required for like another 20%, 10%, 15%, I think was the total. So we were left with about, somewhere around 15% of the prior authorization approval requests needed to go through a more specific and detailed process. But we really wanted to test the idea that if you can handle CRD and deliver that benefit as part of a prior authorization transformation, such as we're undertaking, providers get a benefit right off the bat. The productivity improvements are, substantial. The return on investment is substantial. It's somewhat sobering to recognize that so much of what we do in prior auth related communications between providers and plans is unnecessary, but it reflects the fact that we have a lot of sort of satisficing behavior because providers don't know at the point of service whether or not a prior auth is required historically. So they do it for everything. It's, it's kind of an adaptive, maybe a maladaptive behavior, but it's not completely understandable. So we were able to show that kind of result. And I thought that was very, very important for our community. Just to wrap up, we've gone from there to getting close to committing to the technology partners that will need to stand up a multi-payer, multi-provider service that will incorporate the Da Vinci prior authorization implementation guides for as many payers and providers in Massachusetts as want to join. We operate a health information exchange today, servicing many of Massachusetts payers and providers. And we think the future is investing in capabilities like this at the community level, because this is infrastructure. It's rules, it's infrastructure. And ideally, what organizations do behind their firewalls in their black boxes is where the value is. And the pipe is a utility. It shouldn't be, and should be used to the greatest extent, by as many people as possible to generate the greatest impact.
Great, thanks, Denny. And just in time, I might add, just when the final rule dropped, so we're right on top of that. We've heard mostly.
Just don't ask us about Change Health. Don't ask me about Change Healthcare, because that's a whole other thing that we've had. I feel like we're drinking from a fire hose over the course of the last 10 days, but yeah, we're excited about prior auth.
We won't open that can of worms today. All right, so we've heard mostly from the payer side and the implementation side on the payer side with what's going on at Cambia. Let's shift over to the provider side, EHR systems, for a second here, and maybe we could hear from Hans a little bit about, from a leading EHR vendor and obviously large integrator, what your perspectives are on the final rule, and then where you see it going in particular without we don't have the provider side rules yet. So, Hans?
Yeah, the latter part, I guess we might talk a little bit further about, but looking at the CMS rule, the general perspective is that it's a positive step forward. It has been a discussion long in the making, and the question then is that the term infrastructure has come up. Denny just used that perspective, and that's typically where regulations are very helpful to help everybody move along and help everybody move along in the same direction, because that's where we need to have the consistency. But there are also some challenges with that. And Heidi talked a little bit about that. It's a technical and it's a process, a governance challenge. It is a very complex workflow that we're dealing with from a provider perspective, for sure. And I'm sure that on the payer side, that's in many cases similar as well. But looking from a provider perspective and a technology perspective, there are typically many people involved. It starts with the clinician having the interest and the need to have an activity, a service performed. Could start with scheduling. It could start with ordering. It could start in a number of different areas upon registration or the intent. So there are a number of different places where it can begin, and then it has to work its way through. Either the information is readily available, needs to be follow-up, etc. So that complexity actually then also says, well, how much experience do we have with that? And in that sense, a positive reaction to the rules as well, that it points to Da Vinci standards and implementation guides. It is starting to identify that, but by pointing to it in a should way rather than a shall way, it has provided flexibility to learn. This is not going to be an easy one day and we're done type of process. This will take time. You'll see on the provider side that it's not necessarily typically talk about EHR as a monolithic at times unit. You'll see on the provider side that there are multiple systems that are typically involved, particularly when the organization gets larger. It's not just the EHR as the clinical documentation system. There might be a scheduling system out there. There might be a billing system out there from a claims perspective that needs to know, et cetera. So just before you know it, 3, 4, 5 different systems involved. Bob described it in his overview as well. Yes, there you see a block there called EHR, but really it's in the provider side. There's much more going on than just that. So having that flexibility that we can take those guides and then figure out how to apply them best, modify them before we lock that in. When you compare it with the original rules that came out around APIs for a certified HIT, no standards provided, and now we have migrated to FireUS Core. This kind of skip that first step of no standards and everybody does it on their own. Yeah, you could still do it, but there's much better guidance to say with Da Vinci backdrop, we have a place to start. So I think that's when you look at it, the combination of we're stepping in the right direction. There's tremendous value to be had all around by everybody. There's a framework around standards and implementation guides that has a level of flexibility that everybody can work with, and that we can start to figure out how does that really work. I think you'll hear from Raj and Kirk would be able to speak to it as well. Some of the different ways in which that can be approached. What the best way is, how to best do it, step one, will vary from one system to the next. So I think that's a very positive context to begin this work. Yeah, we have a couple of other things on our plate as well with HTI1. I'm sure that people are aware of that. So it is going to be a very busy time for everybody to figure out what are the right steps, how we're going to use technology, and how are we going to fit it into the provider's workflow most efficiently and take advantage of it. So that's going to be the journey.
Great, thank you. Appreciate that, Hans. Appreciate that perspective. And you teed up Bob perfectly. Although if we haven't already got enough information out of Bob, can you speak to the potential impact that these, let's call them adaptations over time, could take on the future iterations of the IGs and the fire use cases? Do you anticipate further changes in those? Bob, you're on mute, if you're still there with us.
Actually, I stepped away for 1 second. Could you repeat the question and I'll be happy to answer it?
Yeah, sure, no
Sorry.
problem. Yeah, no, you're fine. It's about the potential future implications on the IGs as we go through adaptations of workflow and understandings. As Hans was just describing, there will be a lot of macerations going on within provider organizations, particularly with that have multiple systems that need to integrate with the IGs and the prior authorization workflows. So do you anticipate future impacts on the implementation guides going forward?
Well, I think there's little doubt that as we gain experience in, not just a happy path workflow, but some of the more complex paths that Hans was describing, that we'll see changes. We did try to put much of this at Hans's request into the current implementation guidance on how you could approach having different HIT modules handle different types of interactions. So there is a section in there where we've tried to be far more comprehensive than just a provider black box or an EHR black box and a payer black box. So we've assumed that there may well be, for any particular interaction, a number of stakeholders that are involved or a number of systems that are involved. On the other hand, it was done as basically some guidance. It was not done as part of a formal standard, or part of the formal standard. So I think that what's going to happen over time is we get experience, we're going to turn around and we're going to go and turn this into standards language and say, fine, if you're using an intermediary that handles CRD, for example, here are the interactions you'll have to have, and here are the standards for those. So yes, I see this evolving over time. I think what we've done is a pretty good job of describing the general workflow from provider to payer, payer to provider, for the interactions that are necessary around the happy path of workflow and implementations to support prior authorization.
Gotcha. Thank you, Bob. Yeah, that's That's for sure the case. We're happy with the happy path right now, for sure. So Jen, shifting into a different vendor discussion at this point, one that we've heard before and that was just referenced earlier with MCG, and everybody knows Raj as a part of our sub-work group, co-chairs group here at WEDI. Maybe you could describe for a minute, Raj, some of the challenges that you've seen people facing with adoption and moving forward with APIs, particularly around prior authorization, and any other technical hurdles you see organizations facing as they go forward.
Yeah, thanks for that question. I think Heidi mentioned it very well, that what is the problem we are solving? Is it just business or technology? And with the 3 payer implementations and 4 provider implementations so far, what we have learned is that it's really both. Let me speak to technology for a minute, then I'll come to the business side. On the technology side, for instance, with the recent implementation we have done, like Hans mentioned, between a provider and payer, when we counted all the APIs that has done the transaction, there are about 15 APIs, right? Between what provider is giving, what payer is giving, and then how we are orchestrating in between. So when you think about an implementation of a prior auth, which need to work perfectly for a provider to adopt, and then you expect the standards and the technologies and the APIs to work, it is not a mere task. It's not an easy task. So it requires quite a bit of technology lift, whoever is implementing it. A lot of times we are dealing with legacy systems on both sides, not able to support some of the technology advancements we need when we support a distributed transaction. For example, if the provider systems are down or the payer systems are down, can we hold it in the queue and process it? So what we have seen with these implementations is it's not just implementing a process, it's also implementing and understanding what is the technology lift behind it and allowing that to advance on both the payer and provider side. And ultimately, what we learned is that it's going to take a lot of time just to advance this. Does it require prior auth? Can we just answer that question? Can we just make that work before we go to the documentation requirements? If we take the whole thing, it's going to be quite a daunting challenge. And also you're setting the wrong expectations for both sides, thinking that you can make it happen within a year. Our average implementation was like 18 months, between 8 to 18 months. Cambia was pretty fast because they're technologically advanced. So that is the clinical side. I have a few more details I'll share during our presentation. On the business side, what we've learned is that when we go to the providers and saying that this is ready, we can implement it, and their enthusiasm is pretty high. Their expectation of this should work and make a difference within 20 days or 30 days, because once you give a time frame or any expectation, then you're counting days. The moment they run the first one and they fail, they're like, oh, it doesn't work anymore. So it's really a game at that point. So what we learned is that you need to have really a good champion on the provider side to understand this workflow change management is much bigger than just telling them this will work from tomorrow. You have to go through the process, and we learned it took 30 to 60 days for us. And we really have counted how these things work, not excite them too much or underwhelm them, but you have to take them to the journey, because after 60 to 70 days, you can see the automation working and they get the excitement. But if you excite them up front, you lose them pretty quickly. So that is the business side. So I hope that helps, and we'll share a little more details later.
It does, and we're looking forward to your presentation, Raj. Thank you. Brian, similarly, from your perspective as a vendor, what are some of the consistent business process hurdles? You've heard quite a bit of talk about workflow, et cetera, that you've seen health plans face in adopting API technology.
Yeah, so I think one thing that Heidi and everybody are bringing up is this concept of technical versus business and working together. I would even go so far as to say, remove the barriers anywhere you can, and let those teams work together, because you're not only getting into the technical aspects of 15 APIs, you're getting into, okay, before, let's say you got a fax, you had all the data that you needed right there on an image. Now this data may be coming from different systems on the provider side, sourced from different places that may not even be connected in the provider's workflow, yet you as a payer may need to validate provenance of that data. How do you do that? How do you even have that conversation as an actual business entity, right? And quite honestly, the people on the business side that are just like, oh, send me this record, may not be equipped to even ask the question in the right way to get the right answer, right? So there's a lot of thinking about what do these new technologies mean in the context of how I actually operate business that needs to happen as well, to be sure you've got the right tools to support all of this technology that you're building, right? Because if you build it, they may come, but as Raj said, if it doesn't work, they'll just walk away, and then you've invested all this for nothing, right? So really think about that end-to-end business aspect of supporting and provisioning that connectivity, understanding who's connecting to who, what that means to your business stakeholders. Same thing for the API interactions, right? If you've got audit needs around, okay, I need to know that the answer that I gave for prior authorization was required was accurate. Well, there's a mechanism to do that in the guide, but are you actually leveraging that mechanism in some business facing process that's auditable that can actually say, okay, I can go look at this one answer and prove that on this appeal we did XYZ. So there's many of these tendrils that kind of leach out of these technical implementations, and you really need good communication between the people that are interpreting the technical implementation into the business process. So your architects, your analysts, anything you can do to get them talking to one another and making sure that they are they have the ability to formulate new processes and put these things together. Don't tie their hands is a great step in the right direction, I think, because there will be business process hurdles that you haven't even thought of yet that will come up as a result of a lot of these implementations.
Great, thanks, Brian. That was a great answer. Shifting then to Mike for a minute. So you're also a vendor in this space, and we understand that there's payers not covered by the final rule, as Lorraine was describing originally. How do you see? Is there a way to sort of figure out a way to support or get the value of supporting these APIs to the non-covered payers, non-covered by the rule payers? Do you see any opportunities there?
Yeah, there's certainly value for those that are, let's say, voluntary early adopters to take on implementing these standards. We have to remember that those that are not covered under the rule will still have to interact with those payers and providers that are covered under the rule. And if you take it from the provider's perspective, when they have to interact with payers that are covered under the rule, the bar is set that all payers that they interact with should have similar interactions, right? So having things one way for those entities that are covered under the rule, and having things another way under those for those that are not covered by the rule, is not something that is a sustainable position for either payers or providers. So that's where when you take a community view, it's important that voluntary adoption be considered. From a selfish perspective, if you will, if you're an organization that may not necessarily have to comply, but you have lines of business that are impacted payers, you have to take a serious look at doing this across your lines of business so that you don't have multiple ways of supporting this that into the future will come into conflict. So it's a matter of streamlining your own business by adopting these standards as well.
Gotcha. Yeah, no, it sure makes sense to me. We're just trying to figure out if other people have other thoughts about how to incentivize that, but I appreciate your perspectives there. So then let's shift back to Kirk then for a minute, because we had another question about the engagement of the provider trading partners, as he alluded to earlier in his comments. So could you just maybe talk about how you first identified and worked with provider trading partners? And obviously you've got a close relationship there.
Yeah, I think this kind of gets to the previous question as well that Michael was touching on about the value of doing API-based exchanges. Not because you're being mandated to, but just because it's a more efficient, better, cheaper, more secure way to exchange data. When we first started as a company engaging with providers to get them interested in this space, it actually was not a hard sell at all. And the reason for that is we have the benefit, if you want to think of it as that, of operating in an environment where the current state is incredibly broken. And both sides know that. Payers know it and providers know it. The way that we exchange data between our entities today, absent open standard APIs, is incredibly expensive. We pay a lot of vendors to sit in the middle of us unnecessarily. We have a lot of humans who need to do things manually that's very costly. And most of all, the patients that we support, payers and providers, are very frustrated, and understandably so. So that part of selling something, which is getting your audience to understand the problem that needs to be solved, is pretty easy in the interop space. Once we were able to do that with some providers, then it really just became a question of implementing the technology. And this is maybe an opportunity for me to say a little bit about the difference between what a first mover, like what Regents has been in this space, required a lot more investment, a lot more time, a lot more working together with a provider than it's going to require all the other payers who are out there looking at this rule and thinking, oh my goodness, how am I going to do this? And the reason I say that is because we'll just stick with prior auth. There is no, certainly was no, 2 years ago when we started working on this, provider side capability to do Da Vinci prior auth. The EHR vendors out there don't have it baked in yet, and there weren't smart apps on the market that did it yet. And so we plugged that gap at Regents by building a smart app. And that took a lot of work. It took a lot of sitting down with provider partners and designing user experience flows and what they wanted. But to be really clear, if you're a payer and you're looking at these rules and you're thinking, oh, what do I need to comply with these rules? You just need the API. You need the FHIR APIs. That is the payer obligation, not just in the prior auth rule, but generally all of these interop rules and mandates are introducing a new paradigm where the entities, whether you're a payer or provider, you really need to focus on your API specifically. If you're a payer and you're thinking, oh, I need to build a smart app like Regents did, stop. You don't need to do that. You shouldn't do that. Payers shouldn't be creating the user experiences of providers for the simple reason that if we as payers try to do that, providers are never going to get to where they want to be, which is a single experience that works across all payers. So as first movers, we had to do a lot of things that most folks aren't going to need to do. They're going to benefit from some of that user experience design and investment that was made. But now the provider side gets it. They understand what they need to do. You're going to start seeing this functionality baked into EHRs, or you're going to see technology vendors creating that functionality, say in a smart app way, and selling it to EHRs. And that's great, provided that what they are selling is going to work across all payers, whether they're customers of that vendor or not. That's the real key.
Yeah, that's a great answer. Thank you, Kirk. That was very well explained, and I couldn't agree with you more about that need for consistency on the provider side for adoption. That makes all kinds of sense. Heidi, so then from your real world perspectives on this, taking this a little bit further, have there been sort of on the front end, let's call it the CRD and DTR workflows, have there been benefits there in reducing front end, both payer and or provider burden that you could describe? I'm thinking of burden reduction here.
Yeah, and I would fold in the member to all of this at the end of the day as well. So as we've been able to, as I've mentioned, digitally build out our criteria and requirements, at the same time, we're surfacing all the data needed to support that prior authorization. And where I can, I'm starting to automate the clinical pulls out of the chart. You often have in the provider's office non-clinical staff sitting there, and they don't always know what to give the payer. So then we get into this horrible transaction of well, payer doesn't have enough information. They go back, they call the provider usually. Provider doesn't return the information, and then it just becomes this back and forth. So I'm trying to eliminate that as much as possible at the front end and get the information we need the first time. I would say too, you know, as I mentioned, the PA check is the greatest utilization of this workflow. And I'm extremely excited that within the EMR, they click a button and run into the PA check. We can actually start to automate some of the form fields within that PA check. We have a goal to automate even more of those form fields, and that's exciting because then you're really starting to reduce the human error, but also the burden. I'm excited to report out, since we've gone live in October of 2022, all out of all the inquiries into our workflow, we have given the provider an immediate response 89% of the time, and that's over 3,000 transactions. I think we're up to almost 4,000 now today. So we are giving them an immediate response. So for the member and the patient at the end of the day, they're getting that immediate response of whether PA is required or not, and if it is, trying to drive as much automation and instant approval as possible. So the other thing that's exciting is the providers using this have also done time studies across all the different ways they submit prior authorizations. And they've been actually able to double their productivity with this workflow. And I would credit a lot of that was when we built this out, I sat down with the providers in several meetings to say, what do you need and how do you need it? And that was with their frontline staff. And so we got lots of really good feedback from them regarding, you know, what kind of experience they wanted and what was intuitive and not. And so I think we were able to build a workflow, right, that worked for the providers, but also worked for the payer. Again,
did we lose Heidi, or is that just me?
No, she's going.
It's fine.
uh-oh.
No, you're fine, Heidi. Keep going.
Can you hear me?
I can hear you. I don't know if Kirk
Yeah,
is
I don't know
doing it.
why Zoom is glitching on me. So where did I get left off?
No, yeah, you were just talking about benefit both payers and providers on the workflow solutions, and
Yeah, and talking with them and getting their workflow information, sort of
Yeah,
understanding
okay.
what they need.
yeah.
Okay. Yeah, and I would say we've continued to meet with providers using this workflow to you know, they've been giving us active feedback as they use it even more. And it's exciting for the providers to actually see the payer not only coming to the table to listen to them, but then they see the change happen. And so that just, again, breaks down those silos that exist today and continues to encourage them to use it. So I'll stop there, I think.
Yeah, no, kudos again for the work, because to get those kinds of benefits, I think we're all going to be rushing out and trying to figure out how to do exactly the same thing that you guys have been doing. It's great work. Yeah, so shifting then back to Denny, and I think this will be our last question in this section. We'll shift gears a little bit overall for the panel, but you know, in Massachusetts, you know, there's been a history of payers and providers working well together to identify and solve certain data exchange issues. We know that with NEHIN and other projects we've done around here. What lessons have you learned, or we learned collectively, that you think others could learn to forge similar effective collaborations?
Thanks, Dave. I think there are a few lessons, and I'm sure that Kirk and Heidi have similar experiences. One is, you know, that almost any good technology solution is a hybrid solution. As we get further into the complexities of prior auth and we look at prescription drugs under the prescription drug benefit as an example, that's a burden on providers and patients that we have to figure, and on payers that we have to figure out how to clear. Though the path there is through an entirely different standard and a proposed rule that's at CMS now. So recognizing that, take victory where you can. Your solutions are likely to be hybrid solutions in many cases in order for them to be effective, I think is one lesson. I think what Heidi said, which is really, really, I think pretty profound, is that people who are normally in a seemingly adversarial state, payers versus providers, when they actually get together and they go through the problem and they figure out how to constructively solve it, really appreciate the opportunity to see the world from the other's perspective and to have the others see their world. I think that's a huge part that's been a part of what we've done in Massachusetts. I think there are some systemic factors in Massachusetts that help us that may not be applicable to other states. We have 80% of our beneficiaries are under either not-for-profit state-based health plans or Medicaid, Mass Health. So we have less diversity or less heterogeneity in our payer market than might be the case in other markets where you can have a range of local and national plans or just national plans. So, in some areas, it's going to be harder to move as quickly as it might be in places like Massachusetts. I'd say the last thing we've learned is that the ability to deliver a benefit as quickly as possible, momentum means everything, and victories, however small, are something to be celebrated. And it's easy to lose sight of the near-term victories that you're able to accomplish because you're chasing this broader goal. And people, this is a tough business, and there's an awful lot of burden to be reduced, and people celebrate even the smallest increments of that being taken out of their work. So I would lastly say, celebrate and take advantage of victories, however small, to move the process forward and to keep people engaged over the longer term.
Great, thanks, Denny. Yeah, that makes sense. All right, so we're going to shift gears a little bit now, kind of at the macro level for the entire panel, and talk about some of the opportunities associated with the new regulatory requirements and how best to realize those opportunities. At the same time, we want to hear a little bit more about what these implementation burdens, hurdles, challenges facing each of the stakeholder groups will be, and then what some of those are going forward and how impacted organizations can overcome those. So we're going to go back to Lorraine just for a second here on the CMS side and talk about the compliance date of 1/1/27 for the majority of the final rule, except for, as you guys eloquently pointed out earlier, some of the sort of the reporting requirements and other things. Can you discuss what the additional time offered or afforded the industry to meet the requirements was, and any steps CMS will be taking to assist the industry during the transition?
We're talking about the API?
Yeah, talking about the overall implementation of the rule itself. Yeah, within the rule itself, like what are the, besides the shifting of the date, what the different additional time afforded by the industry was for, and then any step CMS might be taking to help assist the industry during this transition to adoption.
Well, I think as we said, so part of the reason we had the compliance date for the process improvements of 2026 was because, one, we felt really strongly that improving the process for timeframes was really important to begin to change that, the behavior of making decisions in advance, that we didn't require the API to do that. Reporting on metrics was going to be an advantage in really understanding, so what are we doing and how are we doing it? Begin to make the changes there. and for the denials, that those are things that are already happening, to begin to provide greater specificity in what is that information and help providers begin to act on what that denial is. But again, helping the providers, the payers, really think through, why am I denying this service? And let me provide the better information to a provider so that they can begin to act on it. So that we felt could make it, instantaneous or relatively instantaneous analysis of what's happening today and begin to implement those, prior to the API. In terms of helping industry, we really do rely on HL7 and their implementation work group in identifying questions that are coming through, and if they're policy related, beginning to respond to those, clarify those, build up FAQs on our website. And then if they're technical, working with HL7 and their implementation division to identify what those are, then they can put up FAQs or use their Fire chat to identify what those are, really leveraging the beauty of that group to build upon how those things can be implemented. So we work very closely with them. And obviously WEDI is planning to use its forums for expanding the implementation and education resources through existing channels that they have. We will continue to do our webinars and outreach, again, from a policy perspective, because we think that each area has good expertise for doing that kind of thing. So to the extent questions come to us, we'll either answer them or put FAQs up on our website, continue to collaborate with HL7 on the technical implementations, and really, leverage the work groups that they have in place. And continue to monitor. I was just noting, I don't know if the states have people on this webinar, but we really try to collaborate with the state health IT work groups on seeing that they've got people engaged in listening, and what kinds of resources we can provide to them, because they are also impacted payers. And to the extent that they can learn and benefit from the kind of engagement that's happening here would be really helpful for us to know, so we know what kind of education and outreach to do there. That was kind of a long-winded answer, but it's like top of mind for us, and very important to us to leverage as many resources as we can to share.
Yeah, no, that all makes great sense. I don't think anybody was expecting you to show up with a team of people to help implement, but it was just really what kinds of resources and other thoughts that you guys have around that. Appreciated. All right, coming back to Kirk, we're going to get a lot of mileage out of Kirk and Heidi today, I think, because they're willing to talk to us. A plan that's already taken advantage of API technologies. Was there any internal, sort of sales pitch or communication that had to happen internally to sell to your decision makers? This whole idea of these APIs, even before obviously the government, federal rule, which just came out.
Yeah, and as I touched on a little bit before in the context of how did we sell providers, many of those same concepts are what we use to get our own internal business partners excited about the opportunity of open standard APIs, which is that it's not difficult for them to appreciate how broken it is today. And we know how much we spend on data exchange absent open standard APIs. I think, given that Regents has been moving a little bit ahead of the curve here to try to demonstrate the viability of this concept, that required some additional investment. And that wasn't an easy sell, but I think fortunately, Cambia has a long view and is focused on its cause of being a catalyst to transform the healthcare industry. I mean, that's what this work is. And so, ultimately we were able to say, look, in the long term, this is going to benefit all of us. It's going to benefit the members that we serve. And I can't remember who it was who said it earlier, but it's exactly the right mindset. It shouldn't be anybody's differentiating characteristic or secret sauce that they can securely move data around the healthcare system. That should just be the basic utility that we all essentially can someday just take for granted. And then everybody can compete like cats and dogs and innovate on top of those basics. But healthcare has got to get the basics right. And that's the way we kind of pitch this internally. And fortunately, that was something that appealed to our company.
And Kirk, I was just going to chime in really quick too. From my perspective, it was really interesting at the time in 2017, our CEO actually put together a group of leaders handpicked in the organization. I was one of those leaders, and his charge to us was, we need to make the prior authorization process better as a health plan. Our members deserve a better experience. You come to me and tell me how we can move forward with the fact that I don't want our members to experience the prior authorization process. And that was his charge and his vision at the time. And it was just kind of coincidental that our recommendation to him at that time was, we need to be interoperable with our providers and have that automation capability. And that came together with Kirk's team, who was embarking on the Da Vinci work at the time. And it was just this perfect collision within our organization on both sides, which allowed us to kind of move forward to where we're at today.
Wow, I think we're going to coin that term, a perfect collision. It sounds like something that should happen in one of those accelerators, but either way, it's great. It's a great visual. And I think it was Denny that was describing before Kirk about the sort of the infrastructure, should just be there. The plumbing, et cetera, should just be there, which we agree with 100%. So then, Denny, shifting back over to you for a second, regarding CRD, the CRD API, what other do you see as benefits that plans, providers, and ultimately patients will realize from this technology? Any other thoughts there?
I think there are, I think the first benefit is going to be the realization that providers who have struggled with prior authorization and said, we don't understand the rules are different for every health plan, they're different for every health plan's line of business, for different beneficiaries. Providers, especially physicians, have expressed the concern that they really need to understand how prior authorization works. And I think one of the great things about successful CRD is you really don't. You just need to know that it works well. It's kind of the old expression, you don't need to know how to build a watch. You just need to be sure it tells you the correct time. So I think having a successful CRD process is going to take a lot of the burden off of providers who feel, if I can't understand it, I can't trust it. If they start seeing decisions turned around quickly that are favorable, that reflect that the health plan hears what they're asking and can very quickly answer the question, do you need to ask any more, with a no, is going to give providers a lot of breathing room and a lot less kind of this feeling that they have to be super vigilant about the prior auth process. I think it's good for plans because it builds a sense of delivering on what you promised and doing it a lot, which is, you don't get that very often when you implement complex technology processes, which is the first step you can do will eliminate 60 to 80% of prior authorization transactions. You usually don't get that in a complex technology implementation. That usually comes at the end where the real benefits are forthcoming. But this kind of been flipped around with prior auth, which is a whole lot of effort is being wasted on just getting the thing started and trying to get a basic answer to a question. So I think that's a huge plus for both plans and providers. Obviously a huge plus for consumers. I think the last thing I would say with respect to this is that as providers start learning more and more about what kind of decisions require prior auth, what kind of services and items for their particular patients require prior auth, they're going to get better about accommodating and adapting to prior authorization requirements. And I think what Bob Dieterle presented as all those points of contact in the CRD process, from the appointment being made to the order being selected, and many points in between, are opportunities for providers to begin to say, I've seen a lot of patients who have this condition and require these kinds of services. And even if I go beyond CRD, I'm going to get better at knowing what I need to have ready. I'm going to be better at having my data digitized. And I'm going to be pressing my hospital, if I work for a hospital, or my clinic, if I'm there, about, we don't need to hear the same answer to the same question 50 times to realize maybe we can, fix this a little bit on our own and learn more about how the process works.
Yeah, Heidi, you have your hand up?
Yeah, I was just going to add on to what Denny was saying too. One of the secondary benefits that came out of this work that was really surprising to us, we didn't totally fully appreciate, was the providers, even within the large healthcare systems, would in one department prior authorize something, they would refer it over to the other department, and they actually didn't trust the first department's prior auth, so then they would submit it again. So then you've got double burden happening on the
Wow.
same member and service. So because we built out a dashboard that's available to them within their EMR, they can quickly look at that dashboard and see the prior auth was submitted within the EMR. They see the determination or the lack thereof. If there wasn't a prior auth required, they have a transaction ID, and therefore they didn't submit a second one. So it was almost like a double bonus even for both of us as the health plan and the provider. So I just wanted to call that out. There's been some other things too that have just kind of come out of this work that we didn't totally anticipate at the beginning.
Yeah, that's great when things start to become organically evolving in right ways for you. And that's when it really starts to become a great process. And I think that's what Denny was describing, that Bob also talked about at our last WEDI meeting, which is when providers start realizing that if they just collected some structured data, they wouldn't have to fill out the questionnaire form. Bob, you got your hand up?
Yeah, I think one of the things that we tried to do, I think Denny hit on it, and Heidi up front, was to go and provide the opportunity at the order time or appointment book time, to go and provide answers to questions regarding this prior authorization. Is it required? And if so, what do I need to do? The second part of it we haven't talked about, and that is to go and use the standards that we have through the 21st Century Cures Act APIs to gather the data that's necessary to support prior authorization. And if we can automate that, then we take the next major step. Maybe you only have 20% of prior authorizations that require documentation to be submitted, or ones that would have been prior authorizations. But if we can take those prior authorizations that have to have documentation submitted, and 80% of the time we can gather the information automatically, then all of a sudden we take a huge step forward in the overhead that a practice has to experience in trying to gather that information, submit it to a payer, and payer trying to review it manually. So those two go hand in hand to go and, number one, remove the things that aren't necessary. And I think Heidi did a very good job of talking about that, and so did Denny. But also automate the process of gathering the information and reviewing it. I think that's the next big step that we tried to address, and I think we've done a pretty good job of that. So we'll see how it works.
Yeah, no, we're all on the edge of our seat, at least I am, waiting for that to happen, Bob. That sounds great. All right, I want to keep us on track here. We've got about 10 more minutes left of the panel discussion. If there's any questions that folks have, feel free to put them in, and either Rob or Mike or somebody can help guide me to those questions and we can get those answered. But in the meantime, let's shift back over to Hans and real quickly just ask him, if the expected HTI2 rule, which I understand is in the OMB office right now for review, I guess that's the last step before it actually gets released, how would you anticipate the impact of that if it does contain the certification requirements for APIs in that rule from ONC? How do you see that affecting the broader market, and what kind of reaction should we expect to that? You're on mute, Hans.
Double mute got me this time. I thought I was already set. Sorry about that. It's going to be interesting because this is going to be crystal ball. We don't know what's in HTI2. We can ask, and we always get then the reaction, well, we'll see it when the rule comes out. I guess not before HIMSS at the rate it's going. So the thing there is that I think we need to look at two ways. One is that what's already there looking at the CMS interop and PA rule, what's already there with HTI1, and what in itself would that already address, and then what could HTI2 further add to that. When we look at that, there is already now, by having payers identified to have certain APIs, it's kind of what was happening with EHRs, with the FHIR-based APIs. We had to create them as the source, and now other apps, all kinds of apps, are interacting with them in a variety of different ways. We did not need to tell the other party, the client on that side, hey, you have to use this standard through certification necessarily, because it's the only way they can get access to the data, unless they want to go an alternate route, which they can always do, and that's always still feasible. So in a way, we have with PA, we have the same kind of effect, is that now those APIs over the next couple of years are going to become available. Some already in the early stage there, other ones are working on it, etc. So that's going to be there. So that's going to mean that on the provider side, those are the ones to interact with. So for us, EHR vendors and other HIT involved in the EPA flow, those are the ones that we're going to have to work with. That effect is already there. Second part is that CMS put in performance measures that indicate, providing you have to do something, or otherwise you are not going to get a score that is going to qualify. So we're going to have providers asking for this. We're going to have payers interested in it because they're seeing their advantages and benefits out there. So just at this point in time already, over the next couple of years, we're going to see advances but because of that dynamic. Now, an HTI2 could look at some areas and say, again, speculation right now, maybe informed, I don't know, we'll find out, is that how do you, if you are working with, which you don't have to do, but if you're going to work with an intermediary, CDS hooks, how is that going to play in? Or are they going to reference that? That is going to ease some of that transition. In order to interact with the payer, you're going to have CDS hooks. So CDS hooks is fairly mature, something on the provider side. Are they going to look at that? Would that necessarily then accelerate? For some, it would. For other ones, it's already a natural path to be there. If you're looking at other interactions on the provider side, I think that's where we now have to be somewhat cautious and say, what are they going to do? Are they going to give them as shells? Better be careful, because we still have to learn, and CMS providers should, and therefore we have flexibility. The other part is that recognizing that EHRs are not monolithic. So how are we going to carve it up into proper modular support where needed, or that a system can do everything? That's fine. Or I need to interact with multiple systems. I think it's more going to be a question of how are they going to phrase it, and is that going to create a approach that is not going to be very suitable for certain environments, or going to make it hard to do, but we still need to recognize it. I think we need to look at it more in that way versus how much is it substantially going to add to it? I think it can. But we already have a couple of levers out there that are going to help move this forward as well. I think there are places that they can focus on and just augment it and make sure that everybody's going to do it the same way.
Yeah, great perspective on that, Hans. Thank you. Bob, you've got your hand out. Rob?
Yeah, there's a great question in the chat. Both Sequoia Project and ONC have identified prior authorization as a potential use case for the Q hints. And maybe it will just open it up to anybody who wants to comment on that. Huge opportunity to exchange data, but the jury's out on how it's going to work and how should it work. I don't know if there's anybody who wanted to comment on that. Michael?
I'd be happy to comment on that. So yeah, and by the way, there's some really good questions in the chat. I'm just noticing them, and someone was asking about TEFCA and QHINs and what will the impact of it be? I'm very bullish at the opportunity of TEFCA done right in the national scalability of FHIR interop. I think it's a necessity that we figure out how to do this in a way that is not limited to sort of the innovative point things that have been done to this point. And That's for technology reasons, but even more important than the technology reasons perhaps are the non-technical reasons. So that CA, that common agreement aspect of that is huge for national scalability of FHIR APIs. As someone who has put a lot of point-to-point implement Da Vinci use cases into production, the longest pole in that tent has to do with contracting and signing trading agreements, et cetera. That's one of the things that TEFCA can solve for us. Now that TEFCA is essentially open for business, and now that we've seen the FHIR roadmap, which is very aggressive and should excite all of us, it's really time, in my opinion, that we as a community start to lean into that TEFCA model and prove it out and find the ways in which we need to perhaps tweak an IG to make it work well in an architecture where there's a QHIN in the middle. I think, you know, it's not, the cement is still wet in the TEFCA space, in other words. And so I would look for Da Vinci members and others to start implementing their use cases in a way that starts to take advantage of that TEFCA architecture. I know we're going to certainly be doing that, and we're already engaged with providers and having conversations with them to where, you know, where in the past they would always say to us, this sounds amazing. We love the results you've gotten in your prior auth work, but what you've got here only works for Regents. When does it work for United Healthcare and Humana and everybody and all the other blues? That's the place we want to be. And I think that TEFCA gives us an opportunity to start really taking advantage of that build it once and have that single investment that you've made scale to many other entities, even if you don't have an arm's length kind of relationship with them. So long answer, but as hopefully you can tell, I think TEFCA done well is going to be a tremendous asset for us. But we're the ones that have to make sure it's done well. Because you can't design something that complex in a PowerPoint. You need folks to start pairing up, implementing, figuring out what doesn't work perfectly yet, and then fix that. That's the only way this moves forward. And now it's time to do it in TEFCA.
Great, thanks, Kirk. Mike, you had your hand up. And we're just about to wrap here. We've got about 3 minutes left before our presentation.
Sure. So yeah, as Kirk had mentioned earlier, leveraging the plumbing that exists already today, that's largely what TEFCA is about with the QHINs. The QHINs are not brand new networks, if you will. They're new rules to ensure trust in the existing networks. So it's leveraging existing plumbing that's out there. And it's also a matter of scaling FHIR. What we see in prior authorization transactions is that they're largely point-to-point transactions between a provider and a payer. But making those transactions, corralling them into a point-to-point model for the transactions doesn't necessarily follow. So it's really an and. It's a point-to-point transaction in its individual implementation for a patient, and it is a transaction that can be scaled across networks.
Great. Thanks, Mike. And Hans, go ahead.
Yeah, if tying a little bit to Kirk's comment and Michael's together, I think Kirk's point is extremely important, that it's the value that starts with the common agreement. Mm-hmm. And that the technology, where typically networks have been, if you look at the care quality model and the Commonwealth, et cetera, have been a broker document exchange where data flows through the QHIN. I think with TEFCA, we very much have to look at, it's the establishing the trust. So I know I have a trusted party that I'm getting a question from, but a lot of the EPA, and if we want to shift a little bit in the other ones as well, interactions, is that beyond that point in time, I know exactly who I'm connecting with. So we should be very careful forcing it through a QHIN. We need to have the trust, and we can do that. But also keep in mind is that with what's an EPA, I have a very well-known payer I'm going to go to. I know who to go to because they're going to pay. But once there is a follow-up and say, hey, is it do you have the data to support that you're authorized? I can very well see is that the provider who's asking may not have all the data. I want to fan out to others. So I think we need to think about this in a very mixed way, as these are not simple queries in the traditional way anymore. These are highly complex workflows where we go back and forth on very point-to-point and very much a fan out that we have to have. So we need to learn and not be restricted by, and that we have to look out for by a TEFCA that says you can't do that. We have to, I think, work very closely together so that we can take advantage of the top layer and then selectively where needed of the technology, of the record locator service, of other things to make it work. This is a fantastic opportunity with EPA to figure that one out and how to balance it, and others as well. Provider API, CDACs on the other way direction as well, on how can you take advantage of that within the authority of the requester. What can I get? So we have to really work on that and help move that forward. And it's, as Kirk said, it's not cemented yet. I hope that it will not be cemented, but that it will remain flexible to based on where, and all indications are based on discussions and everything else. It is a learning process for everybody to figure it out.
Okay, we are technically over by 1 minute. Bob's had his hand up and we need to switch over to presentation. But Bob, if you have something quick.
Let me do it quickly. I think I agree with Kurt and Hans when it comes to the idea of a common agreement. I think that is absolutely essential, and the TEFCA environment can create that. When we get to fire transactions of the type that we have created within these standards, the facilitated model makes a lot of sense. The brokered model makes far less sense. We have created these to be real-time exchanges. We have not created these to be something where you can accept a long delay or accept anybody in the middle. So I think we're going to wind up seeing the ability to use a common agreement and a facilitated exchange as the predominant model. I think the brokered is going to be a real question that we'll have to answer if it has a place in the overall implementation for prior authorization.
All righty, thank you. On that note, back to you, Rob.
David, great job moderating a wonderful panel. Thank you all. We're going to switch gears, and I want to have Raj and Danny Kaywood do their presentation. And gentlemen, thanks so much for being here.
So I'm going to share my screen in a second.
Thank you, Vanessa.
Can you guys see this?
Yes.
Yes,
Okay,
looks
thank
good,
you.
Rob.
I think the last discussion was pretty, I'm really excited about the TEFCA and what we can achieve with TEFCA. And I really liked what Kirk said. If done well, that's what we need. So really hoping and planning to contribute everything we could do to make that scale on the provider side. So we're going to share not a lot about the rule because you probably heard enough. We're going to share a little bit about what is our experience with interoperability and implementing with regions and Cambia as along with them in the first place a couple of years back, and since then a couple of other implementations. And we talk about what does it take for you if you would like to do this. So I know that you're all sitting here for a long time, so we'll get through some of the slides you're very familiar with. Only focus on the things that are probably where we have learned things and some of the insights. So just to give a quick background of MCG, we operate in the clinical decision support space, providing the evidence-based guidelines to several plans and a lot of hospitals. They use our solution to document based on the evidence, especially in the utilization management space. MCG has been actively participating in a lot of thought leadership, part of the WEDI, part of ONC, part of other places as well. So probably many of you are familiar with. I will have Danny talk about some of our experience with the payer provider implementation on prior auth.
Thanks, Raj. So I think one of the things that we, some of this Heidi and Kirk did a good job of covering when they were talking. I want to point you to the top right here, or the top right where we were talking about that productivity increase. To Heidi's point, a lot of that was due to we don't need an auth, or there's already an auth, or various items under that umbrella of that coverage requirements discovery use case. We'll talk a little bit about that here at the end. We've seen other things, right? So the ability to automate these approvals, as Heidi also said during her part of the panel, you can't, in most states and in most places by law, automate denials. So when we talk about automated decisions, it's approvals. It's, yes, you can go ahead and do this. So we have plans that, depending on the different clinical use cases that you have, you see a very different number of, or percentage of auto approvals, right? So one of our payers is doing 60%. One of them is doing 15%. One of them, I can think of one payer we have doing north of 75%, right? So it is a different, depending on your use case, the type of service that's actually being authorized and how complex that review is going to be, you're going to see different percentages there. But what you can get out of some of that is reduction in the downstream processes. So reduction in medical director referrals you'll see on this screen. You can also see reduction in denials overturned on appeal. That's something else that we've seen. If you can get the information needed to review the request right away, you don't need to make any administrative decisions that you then need to go back and you need to first defend and then go back and reverse. So when you think about this, the compliance element of this from, we've talked a lot about compliance, we talked a lot about the rule. There's real business value here as well. So there is value, obviously, in compliance. I know our friends from CMS, I think, are still on the phone. So lots of value in compliance, but there's also real business value here for payers and providers from a business process perspective that they can look to achieve. My next two slides, if you jump to the next one, Raj, we've already talked at length about some of the different elements in this rule. So I will not focus too much on these and maybe we can just move this along. Obviously, we're talking mostly about that prior authorization API here. MCG, we haven't done any of the payer-to-payer provider access pieces. We focus mostly on the prior authorization space, like Raj said. Raj, I'll give it back to you. We don't need to drain these pieces.
So just to talk about our experience, I think over the last 4 years, maybe 3.5 years, we have implemented with 3 payers pre-firewall, like using all the APIs they have available. We have done one with Fire, we have done one with X12. So we have done 3 flavors, which includes a Fire and a custom API and an X12. And gained a lot of experience through this process. We have done the prior auth as well as all the review types in the inpatient pool as well. So we have seen implementations varied from 8 to 18 months, depending on where the provider is and where the payers are in terms of implementing the CRD, DTR, and PAS. The things that we learned is that, so the payer and provider implementations, you have several people on this, both the business and technology knowledge and their expertise. So bringing them together, I should give a lot of kudos to Regent's team, where Heidi and team done a fantastic job reducing this time frame, bringing them together. They sat with them, outlined all the processes. But when we are working with others, we see that is taking quite a bit of time just to understand where the processes are. As much as we think we have all the technology to lay it out, all the process one end to another end, but it's not really, it doesn't work that way. You just have to bring these people to understand where they are today, what processes they have, what tools they have, before you overlay the new process on top of it. So we definitely say Fire is the best path, but not all systems are Fire compliant. So, what do you do with it, right? So depending on where you are, how do you advance that? Some are fast enough to implement the Fire APIs, but others are not. But one thing we have seen is that when we are done with the implementation, after regions, we recently just finished another implementation we'll share probably next 2-3 months. But they're submitting like 70-80 authorizations and getting real-time processing, and you really get providers buy-in when they see the results. There's a lot of groundwork you need to do to get that far, but they only believe when they see the results, and that's true any day. But that's something that we have to plan, as I said in the previous comments as well. So I'm going to skip a couple of other slides. I really like this slide. When I read the whole rule, 822 pages, and I outlined, commented everything, highlighted everything. I thought about like, what is the one thing that I can tell people about the CMS rule in terms of benefits, in terms of what they like to achieve. I know Danny covered in that slide some of the benefits, but this one slide in the CMS rule, this one slide will cover the benefits. So it's number one, what they're trying to achieve is to enable providers, right, to do things faster and easier. And then, and then number two talks about support a timeliness to this, right? You can do all you want, but if there is not a fast way to get things done that supports the provider and the beneficiary, you're not achieving anything. And number three is it's benefiting the patient, like faster scheduling of services, and even our filing appeals. So that is another benefit we can see from this. And then lastly, reducing or limiting the number of denials and appeals through the process of achieving all the documentation exchanges. So when we are trying to gather the metrics from our payer and provider implementations, we are looking at all these aspects, right? Bob and team did a fantastic job gathering number of metrics through the IGs. You should really go through that. And we use a lot of that, and we use on top of it some others, talking to payer and providers to really measure how much we are enabling, how fast these things are working, and how do we measure number of denials appeals going down, up and down. And when we put those numbers before the payers ultimately and providers, and they can see the value through it, and gathering this information is really key. So a couple of comments on what is required and recommended, and everybody is like, saying, oh, it is only recommended for CRD, DTR, and PAS. I strongly believe in a couple of years, I hope CMS will come and say it is mandated. They said recommended because there is not enough maturity level in these areas. But we do believe that everybody who's designing this solution for your payer, you should think about all these guides. The teams have done fantastic work in the latest versions, putting all the pieces together. So you should have a technology roadmap in terms of where do we, stand with these requirements, and what does it take to, implement it, whether you use the vendor or your own technologies. Even though they're recommended, I believe they give you a lot of value if you start thinking as required. So you may have a couple of years roadmap to implement it, but you should pay attention to that. So the other things that we learned from the technology is the second point I'll call second and third. I mentioned in even the panel discussion. What we've learned is that one PA transaction could be several APIs. Right? When you talk about between provider and payer, and sometimes you involve the vendors in between, it's really a technology, what we call a distribution transaction management. It's not easy at all. I mean, now all the cloud and all the technologies, you could do it, but you should really plan when providers submit something that regardless of how many layers of calls you're making before you get to the payer and comes back, anything can fail in between. And you should have technology and the vendor capabilities to process asynchronously, because otherwise you're not asking provider to resubmit again, right? You're going to lose them through this process. So that is one thing that we learn by failing, and we really incorporate these technologies in place. So when MCG thinks, we purely think as a orchestrator in the middle, exchanging all this information, right? Not trying to too much talk about our solution, but when you think about how do you plan the CMS prior auth rule, we think about 4 pillars when we read the rule, or even prior to that, using our expertise. And how do you, if you are new to this process, given where you are today, how much time you have to make these decisions, and how much time does it really to implement it? So let me talk about that. We have a couple of slides around this, and we really think this is where we can share some of our insights. So in our own assessment, when we talk to the payers, we say you need to have first phase where many of the payers are today, based on number of conversations we're having. They're in the assessment phase. They're like, what do we know about the rules and what is mandatory by 26 and 27, and where we are with our data and with our system capabilities, and then talking to number of vendors, number of internal groups, like to understand what do we have. And I believe, probably between 3 to 6 months, you'll spend some time on that. But I strongly believe the phase 2 is critical. You need to at some point make the decisions, right? Because you need to give yourself some time to implement it. And we believe that is, a large curve. So the decision-making process, before Q3, end of Q3, we believe, in terms of is it build or buy or you're partnering? Who are the vendors? What is your staffing plan? What is your budgeting? Who are the champions? What are the contracting requirements? So this takes a lot of time, depending on how many systems, how many vendors involved in it. So assuming that we get through that by October, you are giving yourselves to implement all the required elements, right? You have the required and recommended standards. So you have to look at everything in between. And you have to look at, what is the change management for your organization. So when we think about that, we optimistically recommend you should plan for, 18 to 20 months. And if it takes less, that's good. But we have experienced the change management cost that much, because it's not just your payer. You have to think about your providers as well, right? So how to bring them on board. The other thing we learned is that the iteration buffer, right? So it's not just that you can go live and everything works. You have to plan an incremental go live. That's what we have been doing. And you bring value to the payers and providers by doing, does it require pre-auth? Get that one first going, show them some value, then you get the other two. So you have to have some buffer to iterate over the process. And then go a little bit deeper into it, and Danny will talk in the next slide as well. One thing we have seen with, when we break it down by each API, the CRD, DTR, and PAS, I'll not go over all the detailed list of issues. Feel free to take a screenshot. But one thing we struggle with our 3 implementation is at this level. And we thought, this is pretty easy to achieve. Like, can we get coverage COB and provider check really well so that we can answer the question? It doesn't require prior auth. But guess what? Based on what we have implemented, this is the most cumbersome process. And to get the eligibility check, like based on the information you get from the provider, can the payer respond? Can the payer see everything they need to see about that member to answer this question? And the provider APIs as well, like, can we resolve to one provider? Can we resolve to the provider network benefits? All that information coming from provider to the point payers can resolve and make the decisions is not as easy as we thought initially. And it took quite a bit of time. And we have seen a lot of errors even going to production with these implementations. And it took like for us at least 30 to 60 days in the last implementation we have done to resolve all the issues, because there are so many data requirements that we haven't seen before. So this is the area you need to understand where the payers are. And then coming to payer documentation requirements, we heard from Heidi, how do you manage the policies, right? You are using probably multiple vendors policies, and you have your own policies. And how do you keep up with all the changes? On top of it, towards the end, Bob mentioned, you can automate this process, right? What kind of documentation requirements you have? Can I get that information from the providers using the file, right? So we played this in this space very well. So we understand this requirement. So, but managing your policies, managing the automation requirements in terms of what data requirements I need for this policy is itself a daunting, task in terms of technology. So when we implemented it, we looked at like how many policies you have. Where do you want to start first? What are your top 20? Can we start there before we go to the other 100, right? So you need to think through this phase very clearly in terms of number of documentation requirements you have, number of vendors you have, what their capabilities are, and all that stuff. And then finally, in terms of prior auth request and responses, and in the prior auth world, it is pretty easy, I felt. to some extent, but when we have done the inpatient review types, you have initial, you have concurrent, you have revisions, you have discharges, you have all these review types, and also managing the request for additional information workflows based on these review types. We find it very complex when we implemented it. So when we think through the prior auth support use case, you have to think through all these responses and how different payers implement different things. So if you're choosing a vendor, you need to think through all these as well. And then finally, provider adoption. And I'll let Danny talk about that a little bit. So Danny, let me take the next slide.
Yeah, so and I think you kind of touched on it, Raj. Coverage requirements discovery, from my perspective, is probably the most misunderstood of these Da Vinci use cases. When we think about the business, and I'm not saying misunderstood from a technology perspective. I think we understand the technology of what CRD is trying to achieve very well. I think what's misunderstood is everybody's understanding of the business logic that goes into it on the health plan side. So when we think through, this is not just a PA list. I think that's the critical one takeaway. If nobody else takes anything away from what Raj and I are talking about, CRD is not just about a PA list, a list of codes. Is it on the list or is it not on the list, right? That is what has been challenging, because when you think about, is an authorization required, what you're really doing is you're setting up the shell of the case. Why CRD is so complicated is because it's where it connects to claims on the payer side for all of this authorization process. So obviously PAS, when you create that case, yes, that's the actual technological link. But when you ask if an authorization required, that's when eligibility comes in, right? So when you think about something like Raj mentioned, coordination of benefits, COB, we've been doing eligibility checks electronically for 15, 20 years via 270, 271. That's great. The responses coming back from those, though, like coordination of benefits, oftentimes you don't get here's who you should go to instead. That's what the provider's looking for at that moment, right? When you think through the provider contracting piece, when you're asking like, is an authorization required? One of the things you have to go through is the idea of gold carding, right? Is this provider gold carded? In order to answer that question, you need to know who is the provider from the health plan's perspective. And what's in the EHR is a tax ID and an NPI. I see a few different health plan folks on the phone. I won't call you out specifically, but for the health plan folks, how many of your provider search services can return exactly one result with just an NPI and a tax ID? I'm willing to bet it's extremely few. And so that's all of the different business processes. You're talking about enrollment, benefits, you're talking about provider contracting in your network team. And yes, there's the PA list and the utilization management teams as well, but there's other pieces in here. And so that's where this can be very challenging. Documentation templates and rules, I think there's been a lot of focus on this one as the big hurdle to climb, and it is in a lot of ways. When we think about policies, we often think of all the PDFs that are posted out on provider.healthplan.com, right? I would say those are going to be hard to turn into FHIR questionnaires. However, you will also find throughout a different payer organization, there's different teams that have already done some digitization work on some of those policies for use in things like maybe your provider portal, maybe in your internal utilization management workflows for your own teams to document. So digitization, your organization has likely already started there in some way, shape, or form, and there's some vendors out there that can help you with that. And then on the prior authorization support side, a lot of payers, I think, have looked at their systems and said, okay, we work with Evacor, we work with AIM. They push cases into our system. We have the ability to create cases. We're good. Maybe. So if your 278 service that Evacor uses to push cases into your system, that's the happy path. So Bob talked a little bit about, we're happy with the happy path. I think, Denny, that was your quote, but we're happy with the happy path. That's great. And when you're starting to do the payer and provider relationship, when you think about those vendor delegates like an Evacor, like an AIM, all the things like request for additional information, all the things like pending it for review and then updating it with more information from the provider side. When you think through provider discharging a patient, you need to close out that case. A lot of times those different pieces are not in your case create workflows, in your PAS workflows that you might be looking to leverage today. And so those are the things that need to be added. You also need to think through the different types of things. So CMS just said items and services in their rule, right? Everything but drugs essentially is what they were trying to get across from our reading. And so that's like emergent and patient admissions. That's behavioral health. So when you think through the types of cases, the different case structures in your own internal systems that eventually flow down to claims, those are the types of things that whatever you have for creating cases today, probably you will need to invest some time and money in updating those things. And then you can do all of that, Raj, if you go to the next slide, you can do all of that and still miss the most important part. And that's the provider engagement part of this. So Kirk talked about it, Heidi talked about it, Denny, I think you talked about it, Hans definitely did. The provider engagement part of this is extremely important. And there's a lot that goes into that as well as a health plan, right? So you should be engaging your network team very early on in this assess and analyze phase of who are going to be our early adopters that we want to work with, who are the providers we're going to lean on to help us test out these APIs, what kind of a relationship do we have with those providers? When are those providers' contracts with the health plan coming up? So one of the things that we've run into as well is, here's a provider that we'd like to approach. The payers network team comes back and says, we're in contract negotiations with them right now, please don't. So all of those different pieces, laying out the provider rollout plan and taking into account all of those different elements, contract negotiations, acquisitions, thinking through providers acquiring each other and what that does to the provider data within your health plan side. All of that is a big part of that iteration buffer, as well as, again, the provider piece kind of needs to cut across all of these different phases and getting them ready to go. So turn it back to Raj here.
Yeah, well, one last slide I have. I know at this point, probably you guys are exhausted, but I'll tell you this one. With the 3 payers that we have implemented, and the questions that we got was that, how many provider implementation do I need to have before I get my ROI? The question is that you're asking them to spend millions of dollars to, advance this prior auth automation, but it is only valuable when you have provider network adopting it, right? We're very bullish on the QHIN and TEFCA, but how long that's going to take, So do we have payers patiently waiting, right, until you get the level of adoption? Because they have seen the X12 world, they have seen the portal world, now they're into the next one, right? So I'm hopefully, in the next probably 12 months, we will get through this. But right now, what wakes me up right now is that, will payers wait that long to get that ROI, to have the providers adopt it? That's everybody's challenge. We don't have answers, but this is what that we are seeing, right? MCG, just whatever it is worth for. At this point, if you're going to pay and implement it, hey, we'll have this up and running in next 12 months. But the next question is that how fast providers can integrate it. So we are looking at every possible network outside, right? We hope QHIN will solve all these problems. But our viewpoint, right, we have our own provider network. A lot of people use to document it. We use that as a point of taking what it is there. We are looking at X12, we are looking at HL7 Fire. We have, Epic supporting some of these pieces. We are looking into TEFCA, showing some of the demos in the next few months. How would that work? We are looking at Epic's paid platform. We are looking at Evality and others. One might say that, you're creating a lot of flavors here. I totally understand that. But we are also dealing with the pressure from the payers, how long it is going to get the providers to use this. Otherwise, I'm spending millions of dollars on this. So this is the place we are going to be in probably next 12 to 18 months before we have, probably TEFCA and a couple of others, leapfrog. But this is an important problem to solve as we are getting through this phase. So just key takeaways, payer executive leadership agreement is critical, because otherwise you're going to spend a lot more time than you need. Payer IT team's assessment of their systems is critical. Don't underestimate their effort. You will find many issues in testing and prod, because nobody knows how many of these things are done with. Nobody knows those requirements. So don't set high expectations to the providers. that as soon as they go live, they see everything running smoothly. That is something we learned. So you run out of their patients quickly. And provider scaling is key. I mean, we are betting on a few things, but that's what end of the day makes it work. So with that, thanks for your time.
Excellent. Raj and Danny, thank you so much. We've got just a couple of slides to close us out here, but I did want to take the chance to thank our presenters today, Lorraine and Shauna from CMS. Bob, thank you again for your technical discussion and input. David, excellent moderation. Thank you for that, and the panel, Kirk and Heidi, Denny, Hans, Michael, and Brian. Raj, thank you for sharing your expertise, and thank you, and Danny, for your support of WEDI. Raj serves on the WEDI board, and we're really pleased to partner with MCG on this program. And thanks as well to EdFX. These two companies have really shown their leadership on this issue, and again, appreciate their support of our educational programming. Just as a reminder, we have two programs coming up next month. We're going to turn our attention to really the folks that need the most help, I think, the small providers and small payers. A reminder, and Michael put some information in the chat, we're going to continue these conversations at our spring conference. We've got tracks on both the PA and data exchange. We do have a block of time on the first day devoted to TEFCA, so you'll want to sign up for that as well. And I think that is it. I just wanted to take 1 second to thank the man behind the scenes, our own Michael McNutt, always does a phenomenal job before the program and during. So thank you, Michael. And with that, we'll say thank you again for attending the session, and look forward to seeing you at future WEDI events. Have a good afternoon.
Thank you.